So welcome everyone to this Take 30. Today's Take 30 will be led by Amber Christ from Justice and Aging. The purpose of today's Take 30 is to learn about the effort by Justice and Aging and Open to develop a Medicaid 1915c waiver options for states to pilot the expansion of oral health care coverage to older adults and other adults with disabilities. Before I start, I would like to address a few housekeeping items. This presentation is being recorded and will later be posted to Open's online community at communities.openoralhealth.org, and I will add that link in the chat. If you aren't familiar with this community, you should go to the link and request a login to gain access to all Open's resources, policy alerts, and network-wide updates. I currently have you all muted, but once the team is finished with their presentation, you can unmute yourself or ask a question in the chat, and we will have time for Q&A at the end. So now I will turn it over to Amber.
Thanks, Valerie, and hi, everyone. Welcome to today's Take 30. So my name is Amber Christ. I'm the Director of Health Policy and Advocacy here at Justice and Aging. I use she, her pronouns. And just a little bit about Justice and Aging. We're a national organization, and we use the power of law. We're a legal organization to fight senior poverty and focus on increasing healthcare affordability and access to economic security. And we do that on behalf of individuals who have historically and currently are denied access to justice, such as older women, older adults of color, LGBTQ older adults, and older adults with limited English proficiency. We believe at Justice and Aging, in order to actually achieve justice in aging, we must acknowledge systemic racism and discrimination and address the enduring negative effects of racism and differential treatment, and promote access and equity in healthcare and economic security. And we do that too through internally through recruiting, supporting, and retaining a diverse staff and board. So today we are focusing on HCBS waivers to improve oral health. So we're gonna set the stage a little bit around older adults and oral and overall health, just generally, and kind of discuss a little bit kind of the barriers beyond just oral health coverage. And then just really dig into what are HCBS waivers and how can they help to expand access to oral health coverage. So we're going to talk about what are HCBS waivers, what benefits HCBS waivers could possibly include to increase access to oral health, and also just a little bit at the end around other Medicaid waiver options to improve access to oral health coverage for older adults and adults with disabilities. And I'm going to try to leave a little bit of discussion time at the end. If I think Valerie mentioned this, but if you have questions, to pop those into the chat or wait until the end and come off mute. So just a little bit about oral health outcomes among older adults. And I just want to start off by saying too that the data around adults with disabilities that are not older adults and aren't individuals with intellectual and developmental disabilities, there's just not very much data around individuals with disabilities just broadly across the lifespan and their oral health outcomes, which is really problematic. So the data here is really around older adults and their oral health outcomes. So about 1 in 6 older adults experience root caries, 60% have gum disease, 10% has severe gum disease, and we see significant disparities based on race and income and where one lives in the country. If you live in California or Michigan versus, say, West Virginia, that has the poorest oral health outcomes in the country. And then the disparities based on race, I have here 18% of Black and 25% of Mexican American older adults have severe gum disease. 13% of older adults have complete tooth loss. That's a significant decrease over the last few decades, but it's still alarmingly high. And the disparities, particularly based on race, are very high. Black older adults are 2 times more likely than white older adults to have complete tooth loss. And then, of course, based on income, those living in poverty are 3 times more likely to have complete tooth loss than those who do not live in poverty. Oral cavity and cancer deaths are highest among older adults, age 65 to 74. So we see a lot of really poor oral health outcomes for older adults. And this all came from the recent Oral Health in America report that was released at the end of December 2021, the much anticipated update to the Surgeon General's report that was put out in 2000. So It has a lot of really great information in it, including an entire section on older adults. Older adults also have healthcare conditions that really increase their oral health outcomes negatively and impede access to oral health. And a lot of these are bidirectional. So most older adults have at least one chronic condition. Many older adults have more than one chronic condition and even more than two chronic conditions. But the chronic conditions that really have sort of a bidirectional impact on oral health outcomes include diabetes, cardiovascular disease, Alzheimer's and dementia. And again, even having these chronic conditions, there are also enormous disparities based on race, income, and where one lives. I think the most interesting here and newest research has come out around Alzheimer's and dementia. When you have Alzheimer's and dementia, you are less likely to be, conducting oral health hygiene on a regular basis. So having Alzheimer's and dementia can impact your oral health outcomes. But there's also new research that demonstrates that your risk for developing Alzheimer's and dementia is linked to having poor oral health earlier in your life. So that it's a risk factor, having poor oral health, at putting you at higher risk for developing Alzheimer's and dementia. So it's really critical that we address these oral health outcomes, our oral health issues across the lifespan, but that we're also treating these, the underlying health condition can increase your poor oral health outcomes, and your poor oral health outcomes can make your underlying condition worse. So diabetes, if you're in a nursing facility, the rates of aspiration pneumonia and things like that go up with poor oral health. So all that to say that older adults and people with disabilities have unique health conditions that lead to barriers in obtaining access to oral health care and increase the likelihood that their oral health outcomes will be poor and impede their ability to conduct regular oral health hygiene. That both mean that we need to be looking at ways to expand oral health coverage, so actual benefits for oral health, but that we're going also beyond just coverage to meet some of those barriers that people face, that just having, a cleaning every 6 months isn't going, you might be able to get that cleaning, but you're not able to get to the office. Or when you get to the office, the dentist doesn't have enough time to see you because of an underlying healthcare condition. So we want to be thinking about ways that we can expand coverage options, but also go beyond just like benefit coverage and think more comprehensively about how we actually make that coverage accessible to older adults and people with disabilities. So we've been thinking about HCBS waivers as a vehicle for that. And I'm going to get into in just a second what HCBS waivers are, but I want us to set a little bit of context about how we got here. So in our research around this, we discovered that we are not the first ones to be thinking about HCBS waivers and oral health, that actually Advancing States, the organization that helps support Medicaid directors, previously known as NASWAD, actually has a report out about how states are using waivers to address oral health. And Community Catalyst has put out a paper around using 1115 Medicaid waivers to increase access to oral health. So we're not new in the space, but we really grasped onto it when we were talking to Dr. Chalmers, the new CMS dental director, who said they at CMS are thinking, posed a question back to us, have you thought anything about using HCBS waivers? And we're like, well, we haven't. And at Justice and Aging, we are doing a ton of work around expanding home and community-based services. And that's because home and community-based services help people remain living at home and connected to their communities rather than having to go into an institutional stay. So we started to think about this and work with Open and others to think, and state-based advocates to start thinking about, okay, how can we move forward putting oral health into these HCBS waivers? And we thought that it was important that first we kind of just talk about it and what these things are. So HCBS waivers are come out of the fact that in the Medicaid program, it is all states are required to pay for care that is delivered in nursing facility and institutional settings. So it's a required benefit in Medicaid to pay for care in those settings. It has not been a requirement to do so in home and community-based settings. Over time, in response to the fact that most people want to receive home or care at home and not have to go into an institutional setting. And in response to the Supreme Court decision in Olmstead that basically said that you cannot, states cannot, there need to be options so people aren't unnecessarily institutionalized. There's been expansions in Medicaid to pay for services in home and community-based settings. But they're optional for states to take up. Just like adult dental is optional for Medicaid to pay for, home and community-based services are also optional for states to pay for and develop programs for. But the way that states can do that, and the primary vehicle of paying for home and community-based services are through what are called 1915c home and community-based services waivers. And these waivers are designed to enable people to stay in their homes and address functional limitations for people who need assistance. So the types of benefits we see in HCBS waivers are things like personal care with activities of daily living. So if you need help with getting dressed or bathed or brushing your teeth, if you need help with cooking meals, taking out your trash, going to doctor's appointments, that kind of personal care benefit. There's also coverage for adult day programs where individuals go and they receive services at an adult day setting. There's intense case management, there's transportation, there's food assistance, there's home modifications. The list of services and benefits under a home and community-based service waiver are really broad. Again, with the intent to to provide people the care and the supports they need to remain living at home. There's some real quirks about HCBS waivers though. While you can provide services that are beyond what can be paid for in Medicaid under the Medicaid state plan, the waivers themselves can be limited by population. So we'll see waivers that are designed specifically for individuals with intellectual and developmental disabilities. We see waivers that are designed specifically for individuals with traumatic brain injury, or for older adults or individuals with Alzheimer's and dementia. So we have the waivers can be limited by population. They can also be limited geographically in a state. So you might see some waivers available only in certain counties or by certain zip codes. It's not as common as designing waivers that are limited by population, but there are some states that limit their waivers geographically. And then almost a lot of the 1915c waivers have caps on them, meaning that there are limited slots for people to enroll in the waiver. And so that creates wait lists for the waiver services. So there are limitations certainly around HCBS waivers, but there's also great opportunity in HCBS waivers because they're just they're designed to be really comprehensive in the care and services and supports that are being provided to keep people at home. Another kind of unique thing about HCBS waivers is that they have to be budget or cost neutral, meaning that they cannot cost any more to provide services in the waiver than it would be to provide those services in a nursing facility setting. So basically it's like you're diverting the costs from an institutional setting to the home and community-based setting. So all that to say, there are about 300 or more than 300 HCBS waivers that are active nationwide across the country. So there are a lot of waivers. And the way that these work is that states can put these waivers into place. And a lot of states have multiple waivers, obviously, 5, like 3 to 6, sometimes even more. And they have to be developed. So there's sort of in the development process and in the renewal process, which the renewal happens typically on a 3-year basis, but sometimes on a 5-year basis. The state Medicaid agency has to provide an opportunity for stakeholders to comment on the waiver renewal or waiver development before they submit it to CMS. And then the public gets another opportunity to comment once it's at CMS. So there's sort of 2 opportunities to inform formally, like through a formal process, inform the development of these HCBS waivers. There's also opportunity if you have good relationship with your state Medicaid agency to inform the waiver before that. Like some states have really robust stakeholder engagement, even leading up to the drafting of an HCBS waiver. It just depends on the state, and it depends on like your engagement with the state, how you can kind of engage, but there has to be at least these two formal opportunities to comment. So that brings me to where we can use HCBS to expand oral health coverage. And this is just some examples of where HCBS waivers could include additional benefits and coverage options for those who are enrolled in these HCBS waivers. So you could include covered benefits beyond what are approved in the state plan. And we all know that adult dental from state to state varies widely, from states that have, you know, just emergency coverage up to very comprehensive coverage, and then everything in between. And sometimes the comprehensiveness of that coverage differs based on what population we're talking about that's covered by Medicaid. But the HCBS waiver would be a way to add additional coverage beyond the state plan into the waiver. So it could be additional cleanings. So maybe there's only one per year. It could be two. It could be maybe the state doesn't cover periodontal treatment. So the waiver could include periodontal treatment or dentures or other covered benefits that are not covered. It could include anesthesia services that aren't typically covered, could be billed as oral health coverage. I think another really incredible way that we could think about this is enhanced reimbursement to providers who serve the populations enrolled in the waivers. This could be across the board. It could be for extra time that's needed in order to serve the populations that are enrolled in the waivers. You can think about that reimbursement piece in a lot of different ways. And then there could be, for example, increased coordination between all of the different providers that are working to provide all the services and supports that the waiver provides. So really increasing that coordination between like the aging and disability providers, the dental providers, and the health providers to be more integrated. And when we think about ways to improve oral health outcomes with these populations in particular that have a lot of health conditions and a lot of oral health conditions, that coordination piece becomes pretty critical to ensuring their overall health. So we took a look at the report that I mentioned earlier that Advancing States put out back in 2016. There are 13 states, including DC, that have HCBS waivers with additional services included for dental. That's pretty limited. Like I said, there's over 300 HCBS waivers, and there's only 13 states that are using them, and only for a handful of their waivers. And this is not current. So I took a look at some of these states. Oklahoma stopped their waiver. California's waiver for their individuals with intellectual and developmental disabilities still includes some additional oral health benefits, but its other HCBS waivers do not. And then I took a look at Kansas because Kansas was one of the states that had most of the HCBS waivers in existence right now that have dental benefits, and them are specifically targeted for individuals with intellectual and developmental disabilities, which makes complete sense and should be happening. There's only Kansas is currently the only state I can find that has dental benefits that are in their HCBS waivers for older adults. And the only thing that Kansas had for older adults in their waiver that went beyond anything in their state plan, which by the way is very limited. They have very limited dental coverage in their state plan. But the only thing that they went above and beyond in their HCBS waiver for older adults is coverage for dentures, partial dentures, and full dentures. So there's a lot of opportunity to think about how we can use HCBS waivers to increase access to oral health coverage. I also wanted to just point out that there are other types of Medicaid waivers that also present an opportunity to expand coverage and improve that coverage and additional supports for older adults and people with disabilities. So there's the 1115 waiver, which is a demonstration waiver. So Oregon has, through their coordinated care organizations and their 1115 waiver, they're doing a lot of coordination work around bringing in oral health and to integrating it with overall health. And a lot of work has gone in there to improve oral health outcomes through that coordination piece. And then California, in its 1115 waiver, its previous 1115 waiver, which I'll talk about in a second, they've completely redone, so it's expired. They had what was called a dental transformation initiative that was targeted specifically at children. So not older adults or adults at all. It was the only population served under the initiative was for children. And you can see here it had 4 domains to increase oral health outcomes for children. But you could easily see how you could use an 1115 waiver to expand some of these goals to other populations, right? And might change those goals because of the unique needs of older adults and people with disabilities. California had that dental transformation initiative in place, and then it's redone its waiver into what's called a 1915b Medicaid waiver. But it took some of the things that learned from the dental transformation initiative, and it included that in the 1915b, and then it did some additional things. So from the dental transformation initiative, it took some of the expanded pay for performance payments for preventative services into the new 1915b. It took some of the learnings from the CARES risk assessment for young children into the 1915b. But a big one is that they are covering silver diamine fluoride, both for young children and then high-risk adults and individuals living in institutional settings. So silver diamine fluoride in California is not a covered benefit in the Medicaid dental program, but they're allowing that coverage to be expanded narrowly, but still beyond, still expanding it to certain populations under the 1915b. So it provides, these are opportunities to be thinking about, like, oh, we could be putting some of these things into our waivers. So I'm gonna stop there and kind of open it up a little bit about what's happening in your state. What are some ideas around additional services that we could be thinking about putting in HCBS waivers? Are you advocating currently with your Medicaid agency to include oral health in your waivers? And then if any of you would want to join us in thinking about working on getting oral health added to your state's HCBS waivers, and really thinking critically about if we had to build, I think every state is different, and every state's Medicaid population and oral health needs among its population differ. And so we want to be thinking about, though, are there like at least core things we want to be arguing that are included and advocating for that are included in these HCBS and other waiver opportunities to improve oral health outcomes for older adults and people with disabilities, and really centering that equity. Like, what are the pieces that we can be doing and putting in these waivers that are addressing these inequitable outcomes that we're seeing based on race, based on age, based on disability, based on where you live, that we could be advocating for in these HCBS waivers. So I'll turn it over to Stacy. I see some things popping up in the chat, so
Yes.
maybe I'll keep it on the questions piece.
Yep. Thank you so much, Amber. You have such a nice way of explaining things so simply and clearly to really to break it down for folks. So thank you for that really helpful presentation. So there's a question in the chat from Dr. Bonnie Stanley. What's the difference between HCBS and 1115 waivers?
Yeah, so they're two different federal authorities. The 1115 waiver, I'll start there, is a broad Medicaid waiver that allows states to test different changes to their Medicaid program in the delivery of benefits and in what they're covering. It can be very broad. So in that, when I was talking about California's 1115 waiver, it had the Dental Transformation Initiative in it. In addition to the Dental Transformation Initiative being in that waiver, so was moving individuals duly eligible for Medicare and Medicaid into managed care plans, into one Medicaid managed care, or one managed care plan that's responsible for all their benefits. There's probably 50 initiatives within that 1115 waiver impacting different populations. It's really a way for states to test different things in their state Medicaid, in their Medicaid programs. and learn from those and evaluate those and move them forward. And so only some things can only happen through an 11, like moving long-term services and supports into a managed care. You need waiver authority to do that. And so there's certain things that you have to have these sort of testing waivers to experiment with. A 1915c waiver is very specific to home and community-based services. And like I said, they have very specific requirements around them, and really allow states to target certain populations to receive these extra services and supports to remain living at home. There's a bunch of other things around HCBS waivers that I won't get into all the details. And it's not like states couldn't, in theory, and lots of states do, like will expand their state plan to have a required benefit for like personal care. A lot of states have expanded personal care through their state plan and not through an HCBS waiver. But there's that budget neutral piece. So it allows states to kind of control their budgets, but also help to ensure that people aren't unnecessarily going into nursing facilities. So there's the HCBS waivers, very specific just to home and community-based services. I hope that answered your question. We also have an HCBS primer on our website. It is an advocate's guide to HCBS for older adults and people with disabilities. So you can take a look at our website for even more details about the HCBS waivers.
Thanks, Amber. Other questions? Amy says, are different waivers in Texas are diagnosis specific? They have very different dental budgets. We're trying to better align them. 2 questions and thoughts from Deb. What are the implications of HCBS waivers in states with multiple MCOs in addition to fee-for-service through DHS? And 2, some people require sedation to complete dental care. Could a waiver be used to design a way to triage into timely care?
Yeah. Let me respond to the Texas one. I'm really glad to hear that you're aligning. I think that the HCBS waivers this is the problem with HCBS being optional, right? And this is the problem with adult dental being optional, is that you see a patchwork of programs with all different rules and applications, and it's really hard for people to know what's out there and if they qualify, especially if they have different standards. And so the idea that like Texas is trying to align the budgets and coverage makes a lot of sense to me from just a simplicity standpoint for the beneficiaries who need the services, and from an administrative standpoint. So it's really good to hear. And then on the 2 questions, let me look back at those. Okay. HCBS states with multiple managed care organizations in addition. Yeah, we get really complicated. This is where the states are so different, right? So if I take New Jersey doesn't have any HCBS waivers. They only have their 1115 waiver. And it's delivered through managed care only. That seems to be like, if I think about the simplest way to explain a delivery care system, that seems to be one of the simpler ways to talk about one. But then on the other side, like in a state like California, you have people both in fee-for-service, you have a lot of people in a Medicaid managed care plan, you have dental that's carved out, and then you have people who are on HCBS waivers that you're trying to work with. I think where the HCBS waivers could actually be beneficial here is that coordination piece, that the waiver, whatever the waivers are, there's usually a waiver entity, like an organization or an agency of some sort that's been tasked with administering the waiver benefits. It doesn't mean like it's one provider. It means like there's just like one overarching entity, and that entity can help to probably coordinate like with the managed care plan, or if the dental is within a different managed care plan. So like you might be in one managed care plan for your Medicaid benefits, but then your dental is held by Delta or United, or you're in a different managed care plan for your dental benefits. I think that there's real benefits in an HCBS waiver being like, and putting as a benefit, as a piece of that waiver benefit being that coordination piece, that the waiver entity is responsible for making sure you're getting your oral health And so that means coordinating with among all these different delivery entities, whether it's managed care or fee for service or a different dental managed care plan. And I do think that sedation could be something that could be built in. I think that's a perfect example of where we see a lot of issues is with individuals who need sedation, or channeling Dr. Glassman here, who would benefit from interventions earlier on so that they don't necessarily need the sedation or sedation at a facility site necessarily, but your HCBS waiver could be somewhere where we could build that in. And I just don't, like, we certainly haven't. And I don't think that like us at Justice and Aging are necessarily the best people to be thinking about or have the expertise about like what would be good in the waiver. I think this is where we really want to be coordinating with all of you that see all these barriers, whether that's in an office or if it's like, are there ways that we can think about the delivery system at home that we could be thinking about including as like benefits that all of us could be pushing for in our HCBS waiver renewal process.
Thanks, Amber. I know that we're at time, but if you could hang on just a little bit, can you say, okay, so I want to call on Tanya Dorf-Bruner. And for folks who can stick around for a few more minutes, we welcome you to stay. We will distribute the recording of today's call if you need to go. Tanya.
Thanks, Stacy, and thanks, Amber. And I apologize, by the way, I'm on my one computer that doesn't have a camera, so I apologize for doing that today. So I'm Tanya Dorf-Bruner. I'm from Oral Health, Kansas. So I do have I just wanted to share a little bit of our experience, and I'll make this brief because I know we're over time. Back in, I think it's 2008, we were able to get dental benefits added to our HCBS waivers for people with disability, people with IDD, people who are frail, elderly, people with physical disabilities, and I think the traumatic brain injury as well waiver. Those were in place for about 2 or 3 years until the Great Recession, and then they were cut. And those were really comprehensive benefits. Ever since then, the only benefits that have been in place eventually came back, but only through the MCOs, only through the managed care organizations, not in the state plan. But what we really found is ironic because HCBS waivers are entirely about waiving people's right to institutional care in order to be served in the community. And the irony we found is folks who lived in the community settings had much better access to dental care than folks living in institutional settings. So one of the decisions we, and I mean we, the big consumer advocacy community in Kansas made together was, we don't want to advocate to restore those HCBS benefits. We wanted to get them for everybody. So it took us 12 years. We're literally getting that established now. We could have probably gotten it restored, but when we really looked at what was happening, it just seemed grossly unfair for folks who do live in nursing homes or in ICFMRs, state mental health or state mental or state IDD hospitals. It just seemed inappropriate. So we really advocated to go just for the entire Medicaid program. But I can say, it was great while we had it. It worked well. So I think it's a great thing. It's just getting the comprehensive benefits in the Medicaid state plan is obviously the ideal for everybody. So just a little bit of background about our experience and what we ended up doing.
Thanks, Tanya.
Yeah.
And Dr. Stanley asked, could provision of electric toothbrushes be included?
Yeah, I mean, it really is endless. I mean, as long as like you're proving budget and cost neutrality and it's helping to improve oral health outcomes, which then in fact will keep people out of institutional settings and reduce that cost, then yeah. And Tanya, I really appreciate those comments too. I was thinking about that with the 1115 waiver and the fact that it's not limited to just like 1115 waiver covers everybody in theory, like it would include nursing facility populations too. And so thinking about all of these waiver opportunities as a way to kind of raise the tide and push for the gold standard of having as much comprehensive coverage as we can get in the state plan.
Great. Any other final questions or comments? Well, Amber, thank you so much again for your time today. And again, if any folks on this call are interested in getting involved in this effort, in either helping the effort to develop some waiver options that states might test, or if you think your state might be interested in testing something that's developed, please let us know and we'll reach out to you. Please feel free to email me. Dr. Stanley said she's considering it. We'll reach back out to you, and again, keep the conversation going and look for the slides and recording from today's call to be sent out. Thanks everyone so much. Have a great day.
Thanks all.
Bye-bye.